Thanks for your question. I want to talk a little bit about red and painful eyes, specifically what makes the difference between episcleritis, scleritis, and conjunctivitis. One way to think about red and painful eye, like the Will's Eye Manual does it, is what the location is. So whether the location is in the eyelid, whether the location is in the conjunctiva, the cornea, or some other cause. So another way to think about it is a more practical way, which is when you're interviewing the patient. I want to ask questions to help narrow down the patient the patient cause. So the trauma is a really good one because trauma tells you what you can expect. Is there going to be a foreign body? Is there going to be a corneal finding? Is there going to be a laceration? Is there going to be a ruptured globe? That is all under trauma. Is there going to be traumatic iritis? Is there going to be hyphema? Whether or not this is the first time, if there's a recurrent kind of theme in this person, is this going to be a recurrent corneal erosion? Is this going to be a uveitis? Is this going to be some kind of recurrent scleritis or inflammatory process? So recurrence usually is not infectious. It's usually more of an inflammatory problem. Is the person on any meds? Eye drops usually treat certain diseases. So if the person's been treated before for uveitis, or the person is on a medication for glaucoma like brimonidine, that's causing them to have an allergic reaction. Now, another big question is, what is the main symptom? Is it irritation? Is it pain? Or is it itchiness? Itchiness is straight to allergy. Irritation could be anything from corneal surface, like dry eye disease, or episcleritis. And painful. Painful is something that's more sinister. Now we're thinking about scleritis, ruptured globes, things like that. Uveitis. And then one thing I want to always have ask yourself is this impressive to you? Is this patient impress you? Is this something that is the worst of something that you've ever seen? Is this something that is not that bad? If it's not impressive to you, likely it is not something that is going to be extremely vision threatening. And also, what does this look like to you? You always have a kind of a hidden bias when you're looking at patients, that you have a feeling of what this might be. You shouldn't silence that bias, but you should have that bias in the back of your head while you're examining the patient. But at the same time, don't prematurely close. So open up your eyes or your mind to at other possibilities, and see where other things might be excluded or included in your differential. And also always think about what the worst case scenario is in the emergency room, because you do not want to miss a vision threatening disease. So one quick way to break down is unilateral and bilateral. Bilateral causes such as viral conjunctivitis, allergy, medication. These causes are a little bit less common, but if it's unilateral, anything is fair game. You do an external exam first at the side of the bed. Look at their sclera, without the slit lamp. Look at their adnexa, the lacrimal sac. Look at the discharge. Touch the eye. If they're jumping out of the chair and they're in severe pain, likely it's something a little bit more sinister. If they're not bothered by you touching the eye, then likely it is something less sinister, but with the exception of certain types of scleritis, such as non-inflammatory necrotizing scleritis. Next, you perform a slit lamp exam. Look at the conjunctiva. Are they papillae? Are they follicles? Very difficult to tell sometimes, but papillae are usually a little bit smaller. Follicles are a little bit bigger, and follicles are a little bit more bullous. Only time will help you get kind of to differentiate that a little bit better. And look at the cornea. Is there any corneal abrasion? Is there any infiltrate? Are there little punctate epithelial defects? Are there little marginal white white lesions, like marginal staph? And then look at the anterior segment. This will tell you if it's inside the eye or just outside the eye. Is there cell flare, hypopia, and hyphema? And look at the angle. Is it narrow? Is it open? And the iris, is there any neovascularization? Is it poorly dilated? These are all clues that something regarding the inside of the eye are involved. And look at the posterior segment. Is there any vascular sheathing? Are there any retinal whitening? Is there any vitreous cells? Is there vitreous haze? Is it hard to see at the vitreous for any reason? Is the retina elevated? These are all signs that this is a process that is involving the whole eye, such as endophthalmitis or a panuveitis. And then finally, if you're not sure, you can't see, do a B scan. Look for the posterior T sign, which is a sign of posterior scleritis. I didn't really understand what that was as a resident until later on. Well, basically fluid is in between the sclera and the retina, so it looks like a thin black line intervening. So a little bit about episcleritis and scleritis. Episcleritis is something that does not seem very impressive. This is something that you probably could send home and it would get better by itself. And this is something that should not impress you. And the patient's usually irritated, usually young, usually it's the first episode. And there really isn't any inciting event. It's usually sectoral, only involving part of the eye. It shouldn't be painful when you touch it. If you give them proparacaine and they not feeling any pain, then it's probably just the anterior surface. Scleritis, on the other hand, you give them proparacaine and you touch it, they will still be jumping out of the chair. It is a deep bluish color, and it will not move if you move a cotton tip around that area. Nodular and necrotizing, a little bit easier to distinguish because they look very focal, very impressive. When you have diffuse anterior scleritis where the whole front of the eye is red, it can definitely masquerade as it can definitely look like a lot of other conditions. If you are concerned about scleritis, I would always get laboratory workup, and every institution is different. For me, I just follow the Wills Eye Manual, but every institution is usually dictated by the uveitis service what they typically want to work up. So if you're concerned about scleritis, or if you're not sure between episcleritis and scleritis, since you're in the ER setting, just go ahead and treat it as scleritis. And worst case scenario, you did a lot of extra lab work, but you could be saving this person from or identifying a systemic issue for this patient, or you could be saving them from a scleral perforation. Scleritis, you typically want to follow a little bit more closely, and just to make sure that you see some improvement. And I was mentioning to you earlier, scleritis, the number one cause is usually connective tissue diseases, although infectious diseases can cause it. Infectious diseases will cause a more impressive looking presentation, while the rest of the time, if you're confused if it's episcleritis or scleritis, it's usually in the diffuse anterior presentation. That's usually more of an inflammatory condition. I think that's pretty much about all I wanted to say. Let me know if that was helpful or not.